Hi everyone, our subject today is sleep disturbance in pediatrics. Basics. Sleep problems or disturbance are common concern of parents. They may be classified as dysnomnias, disturbance in amount or timing of sleep, parasomnias, abnormal sleep behavior such as nightmare and night terror, and disruption due to other physical or mental conditions. It is important to understand the normal maturation of the sleep cycle of newborns, infants, and children. In the first year, infants often wake many times during the night, but they may not always cry. The average newborn sleep about 16.5 hours a day with relatively undifferentiated sleep cycles. Sleep-wake cycle become more clearly established by 3 to 4 months of age with an increasing proportion of nighttime sleep. However, there is a great deal in individual variation. In evaluating sleep disorder, it is important to identify inappropriate parental expectation, excessive parental anxiety or stress, as well as parental behavior that may reinforce the sleep problem. Sleep disorder breathing encompass a range of breathing disorder occurring during sleep. These conditions include primary snoring, respiratory events related to arousal, and obstructive sleep apnea. Obstructive apnea is defined as a cessation of airflow at the nose and mouth despite respiratory effort, associated with some gas exchange abnormality and or loss of regular sleep pattern. Narcolepsy, excess daytime sleepiness starting with the recurrence of naps may be early sign of the disease. In adults, naps tend to be restorative but are more likely to be described as unrefreshing in children. Cataplexy, the apparent loss of muscle tone provoked by laughter or strong emotions such as surprise, sadness, or anger is almost pathognomonic for narcolepsy. Loss of muscle tone can range from sagging of face, eyelid, or jaw, blurred vision, and knee buckling to complete collapse with the preserved consciousness. Hypogonic on sleep onset and hypopomic on awakening. Hallucination involve vivid auditory or visual hallucination during transitions between sleep and wakefulness. Such hallucination can also be experienced infrequently by normal individuals. Sleep paralysis is the inability to move or speak for a few seconds or minutes at sleep onset or offset. Normal individual can also experience sleep paralysis, often in the context of sleep deprivation. History and physical examination should first of all identify any underlying organic etiology for the sleep disturbance. This may be easier to identify in cases of an acute change in sleep due to illness or injury. A drug and medication history should include caffeine-containing beverages and over-the-counter medications such as cold preparation. Maternal behavior and attachment, as well as psychosocial stress, have an important role in sleep problems. Perinatal factors such as birth asphyxia and prematurity contribute to increased wakefulness. Children with developmental delay and autism commonly have sleep problems. The sleeping environment, temperature, noise, television in room should also be assessed. A screening tool, BEARS, is helpful in determining cause of the sleep disturbance. It includes 5 sleep domains, each with the trigger question: bedtime problems, excessive daytime sleepiness, awakening during the night, regularity and duration of sleep, and snoring. Snoring may indicate obstructive sleep apnea. Other symptoms may include choking and gasping. A history of repetitive kicking movement may suggest periodic leg movement disorder. An overnight sleep study may be indicated if history suggests obstructive sleep apnea, periodic leg movement disorder, or excessive daytime sleepiness. If possible, parents should be asked to keep a sleep log. This should include the following information: the time of the child awoke in the morning, the time and duration of daytime naps, the time the child is put to the bed at night, the time the child fell asleep, the time awakened at night, and what the parents did. It is also important to review sleep practice and influences. The term sleep hygiene is used to describe habits acquired for reading, for falling, and staying asleep. Bedtime setting practice creates sleep association and include rituals and routine used, such as bedtime stories or song, rocking, or comforting. The child's temperament and ability to self-soothe, thumb sucking, transitional object are important in the ability to fall asleep and maintaining sleep. Feeding practice play an important role. Breastfed infant may be more likely to wake up for feeding. Bed sharing is controversial. In countries where bed sharing is common, it does not seem to be associated with sleep problems. Study in the United States suggests an association. Bed sharing is unsafe for younger children and has been associated with sudden infant death syndrome and other sleep-related causes of infant death. One must also determine whether the bed sharing argument is due to parents' belief or response to sleep problems. History of obstructive sleep apnea syndrome. Nocturnal symptoms include difficulty breathing, asleep, snoring, apnea, and restless sleep with frequent arousals. Daytime symptoms: excessive sleepiness, frequent upper respiratory tract, ear infection, conductive hearing loss, mouth breathing, poor appetite, and hyponasal voice. Other concern: attention deficit hyperactivity disorder, gastroesophageal reflux, poor school performance, and headaches, especially in the morning and upon awakening. Obstructive sleep apnea syndrome rarely produce these symptoms acutely but tend to occur over weeks to months. Parents may note that symptoms worsen with the upper respiratory tract infection. The possibility of sleep disordered breathing or primary sleep disorder should be considered in children evaluating for ADHD. Physical examination, assessment of the child's growth. In severe cases of obstructive sleep apnea syndrome, failure to thrive has been reported. Obesity remains a risk factor, especially in older children. Assessment of tonsillar size. Normal examination is in most idiopathic cases. Children with narcolepsy are often overweight or obese. Vertical gaze, palsy, confusion, poor memory, developmental regression, impaired thermoregulation, and sign of endocrine dysfunction may be present in cases of secondary narcolepsy. How to approach the child with the sleep disturbance after performing history and physical examination. Is there underlying medical problem identified? If it is yes, differential diagnosis. Obstructive airway disease, medication, drugs, acute illness, chronic illness, thyroid disease, asthma, injury, psychiatric illness, depression, attention deficit hyperactivity disorder, anxiety disorder, and neurodevelopmental disorder. If there is no underlying medical problems, sleep history. Night waking, behavioral differential diagnosis, behavioral insomnia, sleep onset associated disorder, limited sitting sleep disorder, partial arousal parasomnias, night terrors, nightmares, sleepwalking, sleep talking, sleep-related movement disorder, restless leg movement, periodic limb movement disorder, and obstructive airway disease. If there is sleep onset problem, differential diagnosis, behavioral, insomnia, sleep onset associated disorder, limited sitting sleep disorder, fears, recent illness. If there is waking problems, difficulty waking, differential diagnosis, sleep deficit, delay sleep phase disorder. If there is waking too early, differential diagnosis, excessive daytime sleep, constitutional, falls asleep too early. If there is daytime sleepiness, differential diagnosis, narcolepsy, obstructive airway disease, sleep-related movement disorder, delayed sleep phase disorder. Recommended investigation. In the vast majority of cases, investigations are unlikely to be required. Polysomnography with the oxygen saturation monitoring is very useful for insomnia evaluation, such as obstructive sleep apnea syndrome, narcolepsy, and nocturnal seizure. HLA-DQB1 can be useful marker in patients with narcolepsy and cataplexy. Top tips. Small infants often have apnea episodes at night, which are harmless, lasting usually less than 10 seconds, and are not associated with cyanosis, decreased oxygen saturation, or bradycardia. Nightmares are differentiated from night terrors by easy recall of the event. Night terrors are usually associated with the cry or piercing scream. The child looks flushed, frightened, and agitated, and it is not easily aroused. The child cannot recall the event the next morning. Obstructive sleep apnea syndrome, which manifests as snoring and frequent cessation of sleep, is an important cause of insomnia. Children with Down syndrome, triangular chin, and long soft palate are at risk for having obstructive sleep apnea. The child may need tonsillectomy and or adenoidectomy. During sleepwalking, parents should not try to waken or restrain the child. Telling the child about the event is unnecessary. If episodes are frequent, scheduled walking may help. The child is gently and briefly walked 10 to 15 minutes before the episode, and this is repeated for a month. Narcolepsy is characterized by recurring daytime sleepiness, often associated with the disturbed sleep at night. Cataplexy, loss of muscle control when, for example, laughing, sleep paralysis, and hypogogic phenomena, auditory or visual hallucination, or hallucination when falling asleep. In contrast to narcolepsy, Killen-Levin syndrome is rare. It is characterized by long and recurrent hypersomnia, hyperphagia, and sometimes hypersexuality. Although many parents and clinicians often turn to medication to treat child with insomnia, it is far more important to search for any underlying cause, an anxiety that needs to be treated first. Red flag. Children with narcolepsy may not only present with the daytime sleepiness, but also with behavioral problems, irritability, and deterioration of school performance. Narcolepsy is a lifelong problem, although the tricyclic antidepressant clopramine remain the main treatment. Remember that it may cause numerous and unpleasant side effects: constipation, urinary retention, and dry mouth. Sleepwalking occur occasionally in 20 to 40% and frequently in 3 to 4%. The typical age 4 to 8 years. Serious accidents may occur. Securing the home, windows, locked door is essential. Be aware of several sleep-related epileptic seizures, behavioral benign, partial benign epilepsy with the centrotemporal spike, Ronaldic epilepsy, benign epilepsy with the affective symptom, benign occipital epilepsy, and Panaytopoulos syndrome, autonomic symptoms, and secondary generalization may occur in these sleep-related epilepsies. Be aware of nocturnal frontal lobe epilepsy, which may mimic night terror. A child with the nocturnal frontal lobe epilepsy has a variety of motor features: kicking, hitting, thrashing, cycling, and scissoring of the legs, and vocalization, shouting, grunting, screaming, and coughing. EEG may help in establish diagnosis.